This conference will now be recorded.
Alrighty, good evening, everyone. This is the AnCan Active Surveillance Group. Welcome to, I believe we have one new person on board, and good to see all you guys back. As you know, first we're going to go through the sponsors that make this possible with AnCan and all the different groups that we sponsor. Those would be Bayer, Novartis, Johnson & Johnson, Myriad, Helix, and Blue Earth Diagnostics. As I said, it's the Active Surveillance Group. If you are undergoing treatment or had treatment, we have different groups for those people, but you are more than welcome to stay. And if you need any information about those groups, we'll certainly give it to you. I recognize almost every face on my screen, so I don't believe that's pertinent this evening. Okay, let's do a little roll call. We do have a new person, Jay, and we have instructed him to get his information together so that we can ask him questions and help him get going on this journey and give him as much information and help as we can. So Jay is definitely going to need some time. Dan, do you need any time this evening?
I'm ready to, depending on what you need. And I am not in treatment or active surveillance yet. I have my follow-up with my urologist tomorrow morning. It's going to get a result of the genomic testing, and then we'll go from there.
Okay, so would you like some time to talk about that, or you just want to wait till you get more information tomorrow?
Sure, I can I can give some numbers, see where I'm at, so that everybody has more information is better for me. I'm in that searching decision-making framework right now.
No problem. Okay.
Have you been here before?
I have not. I got connected to this group through a vet in another group.
Okay. Well, again, welcome, and we will get back to you as a first timer shortly. Okay.
No worries.
Jeff, do you need any time?
I don't think so tonight, Gareth. Thanks.
Okay. And we have Jeff Coleman, and we also have Jeff W. Okay. Jeff W., do you need any time?
Yeah, a little bit.
Okay. Michael, do you need any time? Good to see you.
Yeah, thanks. Maybe just a quick update.
Okay. Richard in Silver Springs, do you need any time?
No, I'm good. I'm just here for old time's sake. This is always
All
a fun
right.
group.
Good to see you. Okay. Alan, do you need any time?
I could. I just saw another doctor yet again today, so I'm confused.
Okay. All right. Join the party. I think there's a little confusion in everybody's head. If they're saying no, they're not telling the truth. Okay. Ed, do you need any time?
I don't think so.
Okay. Andreas, do you need any time, sir?
I do have a question for the group, yeah.
Okay. Bill Wood, always good to see our northern neighbor up there. How you doing?
Fine, thanks. Nothing new tonight, Gary. Thanks.
Okay. Bill in Virginia, do you need any time?
Not tonight, thank you.
Is that a no?
No, not tonight, thank you.
Okay.
Okay.
Thank you.
And Eric, Gary Ireland, it's good to see you. Do you need any time? It's been a while since you, I know you've been busy. You're muted. We can't hear you yet. Okay. All righty. Did I miss anybody, Eric? Anybody jump on?
I think you got everyone. But another important question is, Tosca, do you need any time?
Do I need any time? No, I don't. I'm good. And yourself, do you need any time?
I am good as well. Thank you.
All righty. As soon as Gary gets...
there he is. Can you hear us, Gary?
Can you hear me now?
Yeah.
Yes.
Sorry, I'm all blurry though, right?
Yeah, you're a little blurry. Yep.
All right. Well, I'll take the blurriness over the no hearing. I think I'm okay tonight.
Okay.
Thank you.
It's good to have you on board. All right. Well, without further ado, we do have two new people and a few people that would like some time. So go ahead, Eric. Let you and I talked to Jay a little earlier. So
sure.
Okay.
So Jay, where are you?
I'm just south of Cincinnati in northern Kentucky.
Is that Union, according to your...
Yeah, that's correct.
Cool. And how did you hear about AnCan?
I had joined the Mayo Clinic, I don't know what you call it, support group, if you will. And after a couple days of going back and forth, I forget his name, he's on there all the time. He said, you may want to try this group because I started considering active surveillance after visiting so many doctors.
Cool.
The clinic support group helped a lot, and then identified this group and said, hey, if you have intermediate low or if you consider an active surveillance, I've gone full circle. As many of, I'm an engineer, very anal. I analyzed everything, made charts, and I've come full circle. And finally, I have a plan, I believe.
Okay. Do we have your email to send you reminders for each meeting?
You want me to give it to you now?
You can give it to either Gary or myself directly in the chat if you don't want it to be sent to everyone.
Okay. Yeah, I'll do that.
So either everyone or just us specifically, your call.
I can do everyone. I can give it to you now. That's fine.
Okay. And how old are you, if you don't mind me asking?
65.
Cool. And are you a veteran?
No.
Okay. And when were you first diagnosed with prostate cancer, and how did that come about?
I went to my general physician. We were going on a cruise in February, and I was going to the restroom a lot, and I thought, this isn't normal, so I went. He did a digital check, and he said it was felt spongy, so I had prostatitis. He gave me Cipro, and that helped. But I thought, you know, I'm going to go to a urologist. 65, I've never been to a urologist. I was blessed. So I went, and they did the free PSA, and then those numbers, PSA was on his machine, which was a Roche machine, was like a 5.7. Free PSA was higher. Then he did the MRI and CT scan. And so it kind of progressed from prostatitis all the way to the MRI and CT scan. Then I had the biopsy in February.
All this took place in February, or?
Yes.
Okay.
And one of the reasons why it took me a while, I also tore my rotator cuff at the same time.
Cool.
So I wanted to get that treatment done, which I'm 5 weeks out before I got into any treatment at all. Mm-hmm. Mine was very unusual. I had all 12 of 12 cores were positive.
Oh, wow.
And I've not met anyone who had all 12 positive.
I'm right behind you. I have 11, so.
Okay.
Where are you being treated, or where's your urologist?
It's in northern Kentucky. It's the urology group. They're very, very well known. They're probably the main point of care for urology type issues, probably in greater Cincinnati, actually. So I went to my urologist, and he gave me the results. 11 of my cores were only 3+3, so I was very blessed. One was a 3+4, but only 5% was a 4. No crib form, no perineural invasion, so I'm very blessed except for the 12 of 12. So I was going down the road of treatment. I saw the surgeon who prided himself in nerve sparing, but I've met other people that they went into surgery and end up having no nerves. Then I met with the radiologist. They run an SBRT machine here, a CyberKnife. They've been doing it for 10 years. They just had their 4,000th patient last year, so I felt comfortable with that, and I was leaning towards that. I've only been married 5 years, so ED is very important to me. And everything I've researched from surgery, ED just doesn't sound very, very likely to avoid. I also don't want to be incontinent. So I was leaning toward SBRT. And then somebody on the Mayo Clinic group said, why are you jumping into treatment?
Correct.
you're you have no crib form, you have no perineal, your one section is only 5%. So I went back, and I even the oncologist said any 7 puts you in a protocol treatment. So I thought, okay, that. So I went back to my urologist and I said, I'm thinking about active surveillance. Can you run a Decipher test for me? So he said yes, and he said. So I said, my plan is if it's below, I think it's a 0.5, I'm going to go with active surveillance. If it's above, I will probably pick SBRT. He said, I agree with that plan. And then I'm wondering, why didn't you suggest this in the first place with the Decipher test? I also watched a video that somebody suggested by it was a doctor in Canada, Lawrence Kotz.
Klotz. Dr.
And what
Klotz.
a great video that was. I couldn't believe, that just put me over the top. Not only the slow progression of 1% to 2% going from a 6 to 7, but when you do finally reach treatment, it's still very treatable, not mortal or anything like that. So I thought, I've gone full circle. I thought, I'm just going to really investigate this active surveillance. So I think I'm blessed that I'm a candidate, even though I may be on the edge since I have a 7. But again, it's only less than 5%. Right. The 12 out of 12 bothers me. That just, and I told my wife, I said, so if it's below a 0.5, I'm going with this, because if I can get 5, 10, or 15 years of these non symptoms of the incontinence or ED or even with the SBRT, it bleeds over to your rectum. I would have to get the spacer gel. I even went to my gastroenterologist because I have diverticulosis and I have a high number of polyps every year. And I asked, will this SBRT affect any future treatment for those? Because, in case it bleeds over on the rectum. And he said, I do have patients that come in here with bleeding. I don't know what radiation caused it, but I'm sorry.
Let me back you up a little bit because we're getting ahead.
Yep.
So with your urologist currently, are you happy with him or her?
Yes.
Okay.
I'm still a little disappointed that they didn't suggest the Decipher test and active surveillance, but he did come around. He said, I would tell you if I don't agree with you, I agree with you.
Okay. What's your...
Jay, let me ask you, have you had anything checked with a second opinion? One of the big things that we believe here, be out of the box, the very beginning of the journey, is to have your slides checked by a center of excellence, by either doctor. For instance, we know a Dr. Jonathan Epstein in New York. We know a Dr. Ming Zhao at Mount Sinai. Those are the people that you want to double check your slides. All you do is tell your urologist you want a second opinion, and you ask them to send them to either Dr. Epstein or Ming Zhao. You want to move forward now. Judging less than 5 with a 3+4, you're right where you want to be.
I actually have the form that somebody on the Mayo Clinic sent to me. So I asked the urologist, I said, what about a second opinion on the slides? I said, some people on Mayo Clinic have suggested that, and he wasn't against it. He just said, well, we have a board certified pathologist that read the slides, and I kind of dropped it because and let me ask you, a lot of times I read it, 6 is a 7 or 7 is a 6. I guess if it turns out to be an 8, that's a big deal. But if it's a 7 or 6, I don't know if it would throw me in any different decision on active surveillance or not. But
I think you're right where you want to be. I think you've made the right decision. There's no doubt. I think everybody on the screen is going to interject and perhaps say the same thing, but they're all going to ask you, or they're all going to suggest. We're not doctors. We don't give medical advice. You are judging everything on one person's opinion at looking at your slides, and they're not the best in the business. I don't care if he's a board certified pathologist or not. He's most probably looking at slides of all different types of diseases. These guys are just looking at prostate cancer. So they tell you no cribiform, no peroral invasion. That's terrific. Just have them back up what you think will make you feel better, especially if you said you're an engineering kind of guy that's a little anal. well, that's the route you want to take. You want to get, before you do anything, and I think you're right where you want to be, and I'm sure that's going to be the consensus before the night is over, even with, it's unfortunate you've got, 11 cores, 3+3, but the 3+4 with a 5, there's been plenty of webinars where that there are people on the screen that fit that description. They have 3+4 with a low volume 4. They're right where they want to be. You kind of let the rabbit out of the hat right away, talking to radiation and surgery and whatever. I've been playing this game for 15 years, and I hope to play it for another 15 years myself. So but I don't have that many mine's all 3+3 Gleason, three cores.
I forgot to ask.
Go ahead, Jeff. Excuse me.
Your PSA history, what's the trend been over the past, I don't know, few tests that you've had? And when was the first test?
I know, I'll just go on base my general physician, because I know when I do the Roche machine at the urologist, it's higher. But then when I go back to my general physician, which is on a Beckman-Coulter machine, it's lower. So the last test I got, interestingly enough, it went up during the biopsy, and then a few months later it went down. I don't know if that's typical.
It happens.
Typical. It'll go up after a DRE. It'll go up after a biopsy. As you said, people use different assays. Roche uses one. Beckman-Coulter uses another. I don't know what the VA uses. So you can get 3 different numbers getting 3 different PSA tests. And also, before you had these PSA tests, did anybody give you like any instructions not to have any kind of sexual relationships, not to ejaculate, not to ride a bicycle, not to knock down a wall, any kind of thing like that? Did people give you a heads up?
My general physician did not, and neither did the urologist. But
see,
yeah.
Perfect. These are the people you don't want to deal with. I'm telling you right now, because that's ass backwards. That's one of the things that's very important when you're getting a PSA test, is basically to prepare for it. There's even some supplements that can affect it, but not to a great point. It's definitely anything sexual, ejaculation, and as I said, bicycle riding for a long period of time, and any kind of physical, undue physical stress prior to the test.
Yeah, even a colonoscopy will put pressure on your prostate and jack up the number.
And definitely after a DRE or a biopsy, it's going to go up. It's going to take a few, and everybody is different. Could be a couple of weeks, could be a couple of months before you see a decline.
So what was your last number?
It had gone up. So after the biopsy, it had gone up to on the Beckman-Coulter machine about it was like a 4.7, and then I had my physical. So I said, just run it again, and it went down to a 4.5. To give you an idea, it's gone up. It was 4 years ago. It was a 3.5. It actually went down again, and then it went back up to a 3.6. So in 4 years, it's gone up 1 point. So it's not tremendous.
No, not at all.
That's good.
And
have you had any, besides Decipher, which is a germline, which is the cells of your prostate, have you had any genetic family history testing?
So I went to, I did get a second opinion from, he was an oncologist. I think he was a urologist oncologist at the hospital. And he also said he kind of recommended treatment also, since I had that 1.7. But he did recommend, he forwarded me to genetic testing. I went for the first visit, and I didn't pursue it any further. I'm not sure if my kids would have interest in giving their blood. So I went to the first visit, gave him my history, but I've not followed up.
Okay, that's one thing you can consider, just to get another metric to base your decision on, is if you have any.
Eric, do you want to put up the PROMISE study up on the chat?
I will.
And that's a free.
Can do that.
You can. The PROMISE study is a joint venture that will give you free genetic testing. I've done it myself. Just gives you a little spit in the tube. You send it back, and they tell you if you have any inherent genetic I'm at a loss for words right now. What's the word, Eric? When something's
Genetic.
not right, some abnormal would be, but there's a better word. Jeff,
Okay.
what's the word?
Defects.
Jeff Coleman.
Just
Predisposition.
defects. Yeah, any specific genetic defects that might be caught with a genetic test that would, especially if it's specific, and like that PROMIS study they're mentioning, most of that stuff will be specific to genes related to looking for issues for prostate cancer.
Yeah.
So
definitely pursue that, Jay, for sure.
And it would show if you had the BRCA1 gene or the BRCA2 gene, which definitely puts you in a different situation. Something that you and of course it would be important to your siblings if something like that were found.
There's a free study in the chat that's about to end soon because they're maxed out or close to maxing out, from Promise Color. So click on that and sign up as soon as you can after this meeting, and that's a no cost to you.
Okay.
And that would take care of the genetic side of the situation.
And
Michael?
promise and the color are the same thing, correct?
Yeah,
Right.
that is
Yes.
correct. Yep. And then last question is, how are you feeling? Any anxiety?
I was driving myself crazy trying to make the most informed decision, and I would read something on Mayo Clinic, and then it would push me one way, and then people are saying Tulsa Pro and the cryogenic and focal, which I'm not a candidate for focal because all 12 of 12, but go to a center of excellence, and so I'm all over the place. But that doctor is a Klotz or his video just really, and then I got, everybody said buy the book by, is it Dr. Schultz, I think.
Yeah.
So I bought that, and looking at that active surveillance table, I'm kind of in a gray area, because if I read it correctly, a 3 + 4 could be, according to his chart, a candidate for active surveillance. If less than 50% of your core sample, I think you're active a candidate. But then it also said if less than half of your total cores are positive. And I thought, well, that would let me out based on his table. But I don't know if I'm interpreting that correctly or not.
Well, does your MRI show any lesions?
Two very tiny lesions that were so small they couldn't even put a needle to them.
Well, that's all good
Yeah.
news. And one thing that we're missing here, and I'm guess everybody's going to most probably pipe in about it, is time is on your side, Jay. You do not have to make a decision in the near future, not with the numbers that you've got here, and that book, I don't know when it was published, but that chart is most probably apt to change with everything new that is out, and there's always something around the corner. New diagnostic equipment, micro ultrasounds, AI is going to play a big part. But I think everybody's going to agree the first thing you do is you get your slides, a second opinion from a center of excellence. And like I say, we've got two guys in name that know us, that know AnCan, that work with us. Dr. Meng Zhao will actually take time and talk to you about his findings. You won't find that with most people, and so Dr. Epstein also will actually talk to you. Some of these guys have talked to him for like 20, 30 minutes about their particular case and ask them, what would you do? Time is on your side.
Yeah.
And especially with being anxious, anxiety, you just got to take a deep breath and step back and stick with us. If you like what we're telling you, if you think it's of value, certainly follow up. The PROMIS study for the genetics, a second opinion for your slides. I know Michael had his hand up. Michael, did you want to say something to Jay?
Before we open it up, I had to follow up to the MRI. Did they give you a PIRAD score for any of your lesions? Are they too small?
What kind of score?
It's called a PIRAD score, PIRAD.
I don't think so.
Okay, they might be too small, but thank you. And then let's open it up to Michael in Tennessee. You have the floor.
sorry, I took my hand down. I'm just echoing what Gary said. That form that you showed, the advanced urology form, that is Dr. Epstein. And not to give you any kind of false hope here, but whenever I had 3+4 as well, and on his end is less than 5%, and it came back as a 3+3 once he looked at it. So that may hopefully help reassure you even more.
Trust but verify.
Right.
And the way I understand it, I fill the top part out. I give it to my urology group. They'll send it on, and I think it's $450 or something like that. Does that sound right?
Yeah, that sounds right.
Yeah, and it's kind of tricky.
Do you pay it up front, or how does that work?
I think it's after, if I remember correctly.
I think they just bill you actually.
Okay.
And 65, are you on Medicare?
Yes.
Jay?
Yes, thank goodness.
They might cover the second opinion. I don't really know.
Yeah, Dr. Epstein told me today, I got an email from him. I asked him if Medicare covers the service. He said it should.
Okay. So there's, it'll be $450 well spent. If you don't have to spend it, even better.
Absolutely.
Better. But I think Medicare covers the second opinion. I believe it did for me. Jeff, did you have a question for Jay? Jeff Coleman.
Yeah. Well, first of all, yeah, welcome. And secondly, you've come to one of the best places you could ever come to, and anyone that's been here for a while, and I've been here for 5 years, so I can tell you that it's for sure. You'll get a lot of good information here. Eric alluded to the fact that he's a high volume patient as well, as far as number of cores, and I'll just echo that as well. So am I. So the two of us, and maybe some other people on here too, are in the same kind of boat you are. Now, I don't have any 3+4, but again, your 4%, or excuse me, your percentage of 4 being so low, you're probably a pretty good candidate, right, for active surveillance. And
absolutely.
You mentioned Lawrence clots, and I'll just throw this out real quick. I had a second opinion. I go to Johns Hopkins down here near Baltimore, but I decided to get a second opinion on my entire case a few years ago, and I did use Dr. Klotz. So he says he's not concerned about volume. That means nothing to him, and it doesn't mean a whole lot to a lot of doctors currently. So the fact that you have high volume, again, I think you referred to a chart that you saw in a book a couple years that, like Gary said, might be a couple years old. That's probably not as accurate as it currently is, because there's a lot of more and more doctors are saying the volume of the volume, meaning number of cores, isn't really that drastic to worry about anymore. So you're more worried about the great group, and yours is pretty low. So
thank you, Jeff.
You're probably in pretty good shape. Did you get the Decipher score yet? Or
no, I expect to get it this week or next week. I think that they said there's a 2-week turnaround, and it's been a week or a week and a half. So what amazes me is that if not for that blurb in the Mayo Clinic about Dr. Klotz and the Decipher test, I probably would be all in for treatment. And
well, we've had people that were scheduled for treatment on a Monday and went to a conference out in California and got to speak to a couple of the top doctors and canceled it. He's very happy to be with us doing what he's doing. So hopefully we have persuaded you a little bit, at least to take a deep breath, get the second opinion, get the Decipher score. And again, this is not the kind of disease or situation you can put all your eggs in one basket, because there's a lot of baskets here. The PSA, biopsies, PI-RAD scores, and so on. And they can, it's just like PSAs going up and down. I had a 6 go to a 12 PSA and then go back down. Did I have prostatitis? They couldn't tell me. They didn't know. You can't, if you don't have any symptoms, they're just guessing. Oh, it went up. They give you an antibiotic and say you must have had prostatitis. You could be a victim of chronic prostatitis if your PSA stay on a higher level with having no symptoms. So there's a lot of different things going on, and even if you get a one bad score or reading per se, it should not turn the tide until you yourself, being your best advocate, make that decision. And then, of course, if you were to make that decision somewhere down the road and we don't talk about it, we have a group that can help you out. People have been there, done that, been through it, and can give you the ins and outs as a peer, as a person that is living it, not as a doctor across from you in a desk saying, oh, well, we have a cyber knife. Well, I've got one in New York. They have an advertisement says, you come in for 5 days and life is great. They get it done in 5 days and it should be all fine, not telling you about the possibility of what's on the other end of that quote unquote knife. So
Do you have any bathroom issues or sleeping?
No,
Good.
no. Because, I understood, on the cyber knife, that, if you went into them with any urinary issues, then that is not the,
yeah.
but,
we don't even want to go there.
Don't even
because
say the words. Yeah.
we don't talk about that here. So that would be
Yeah.
for another day. Hopefully never. That's the day you're shooting for. So.
And I know about 4 or 5 that have had their prostate taken out, and the ED is rampant.
Yeah.
One guy was taking the injection, and then he got Peyronie's disease from the injection, and he could no longer take the injection. So now he's using a pump, and it's like,
yeah, they're the horror stories that we don't want to talk about.
Right.
So we'll have to cut you short on that note because we don't want to go there.
Yeah.
Did anybody else have questions for Mr. J? Jeff?
Go ahead.
Scott, I got one more thing to add, because Jay, when you mentioned you're getting the Decipher test and you're going to utilize 0.5 as maybe your cutoff point, right above or below, to make a decision on AS. Mine's 0.47, so it might as well be a 5. But that's just in the intermediate range. So actually, you can go up to I've got it here. You can go up to a 0.6 out of it's the wrong one. You can go up to a 0.6, and that's still in the intermediate range, intermediate risk.
Okay.
Just an FYI. So I'm saying I'm being in the kind of the same boat you are with the number of cores, et cetera, the high volume, but with the Decipher being 0.47, I'm still on active surveillance. So maybe that 0.5 is, that's up to you, but maybe that 0.5 isn't necessarily a criteria to use. Like, use all your other tests as well, or all your other data, like Gary.
Like I say, you can't put everything in one
Right.
basket. And of course, Jeff is getting treated at Johns Hopkins, which is one of the premier center of excellence. So he's getting his favorite doctor, quote unquote.
Okay. One question I forgot to ask, and this is probably a stupid question. Surely they would have sent out the one biopsy of the 3+4 and not the 3+3s. Is that a correct assumption? Okay.
The Decipher gets the highest grade sent to them.
Okay.
Just to give you a context, I'm high volume as well. And I think my Decipher was 0.36, if I remember correctly. So not bad.
Michael, you had your hand up. Do you have something else for Jay?
I was just going to kind of reinforce that the name is what it means, right? It's active surveillance. So as a data guy myself, even after you get the data you're looking for, you still have to be very vigilant. Yeah, you do have to stay active and watch this stuff. And I didn't know if anybody wanted to go into the standard routine as far as how often the PSAs get checked, MRIs, things of that nature, but just what active surveillance actually means.
Absolutely. Staying active and being the best advocate, being in this group, asking questions, learning something. People basically learn almost something every week that somebody went through a new test or a different situation. And of course, the protocol, you might have to do PSAs every 6 months. The doctor might want you to do it every 4 months. It varies. Different people do it every 6, every 4. MRIs, basically speaking, there's a lot of us that have an annual MRI. At least you want a second MRI so you have a baseline, something to look at. And some people want a confirmatory biopsy. After the first biopsy, they want a second one. And then after that, it could be from 3 to 5 years to get another biopsy. It depends upon the doctor. It depends upon the institution that you're going to. But that's for down the road. Right now, I think you've got everything in hand and you're right where you want to be. I think, like I said, you should take a deep breath because you don't have to make any decision anytime soon. And I think you're right where you want to be.
Thanks, Michael. And Jay, do you have any more questions for
Yeah,
us?
two left. One, they did mention, I said, what does active surveillance look like for the urology group here? And he said, PSA every 6 months. He said biopsy in another year. So I guess they want to establish a baseline at year +1. And then I said, well, how often after that? He said, depends on what that biopsy looks like. And I thought, okay. And then the MRI, I think he said was 2 to 3. The other thing I need to come to terms with is learning to live with this. I've busied myself so far. I had my shoulder surgery and have been doing all this research. But then when you come, okay, I'm active surveillance. Some of my friends that have had this said I couldn't live with this inside me. I wanted it out. I wanted it out right away. Their numbers were higher. So I've got to pray, I guess, that I can, be content with this, knowing that this is in there. But it's, as you stated, it's not nothing. It is a plan. It's active surveillance. It's not just sitting back on your hands.
Correct. And being active.
If anybody's had to come to grips with this being inside of them and accepting that.
Yeah. What was your last question?
How has anybody had any trouble initially, or how do they deal with knowing then they have cancer inside of them and they're doing active surveillance, but not a treatment yet?
I think that's what Eric was.
I think. Go ahead, Michael.
I was just going to say that's why Eric asked how you were mentally, because that is an ongoing struggle, right? It's one of those things that every time you get your PSA checked, or every time you get another MRI, every time you're going to have those, I need to do something about this again. And that's where this group really helps out. So come back, tell us the results, and these guys will really help you out.
Thanks, Michael. AnCan does have another group on Thursday nights, every Thursday. It's called Men Speaking Freely. And you can talk about anything you want except any kind of treatment. So if you just want to talk about whatever, that's the place to go, and I highly recommend it.
About how you're feeling, because I'm sure there's other people out there. I've been on active surveillance for 15 years. I never questioned, I've got this inside of me, I got to get it out. That was, I'm on the other side of the spectrum. Everybody laughs, but my deal is I came in with all my parts and I'm going out with all my parts. So that's my take on this whole thing. And I've been lucky enough to have my appendix, wisdom teeth, gallbladder, you name it, it's still in me. So that's the way I plan to go out. So I don't, but there are a lot of people that struggle with that. And that's a very important point. That's why we ask a kind of anxiety level. But it sounds like, you've gone full circle, getting as much information as you can and continue to do so. But you can tell from everybody here, you've got two people that have very similar situations as you do, and they're right here where we think they should be. Okay.
Mr. Rick, welcome.
There's Rick Davis, the founder of
Here's
the
our
AnCan
founder of AnCan, the man himself. Uh-oh, we can't hear you. Something's weird. You're unmuted, but we can't hear you yet.
No, it's picking up the wrong microphone.
There you go.
It keeps doing it. So I just wanted to make one slight correction. It's not every Thursday, Men Speaking Freely. It's the first and third Thursdays.
My bad.
So you're very welcome. There's a meeting tomorrow night at this time. And that's a very good topic to bring up. How do people deal with having this cancer inside them? Although there are a lot of guys in that group who have more advanced cancer, but it's a real bona fide topic to bring up in that group. We had a guy come into the advanced group. I'm sure you probably know, Jay. We have 4 different groups right now. for different levels. And we had a guy come into the advanced group yesterday, and Dr. John was moderating, and I had a feeling something wasn't quite right from as soon as he got on and telling me, and he's telling his story and telling his wife used to work at a urology and Well, it turns out this guy was in the wrong group. He had 3+3, but he had a little bit of 3+4, but we didn't get to him quick enough. He was already three treatments into SBRT. And, I wish he would have come in the week before. We would have sent him to this group, and he'd probably still have an intact prostate.
We got another newbie, Mr. Dan.
Good evening, guys. How's it going?
Good. How are you? Do you want to take this one, Gary?
No, go ahead, Eric. I'll just
Okay.
follow along.
Welcome, Dan.
Thank you. I appreciate you guys being here. It's great. I am in the information gathering section right now. So I'll run through, start answering the questions that you already asked, and then you can pick up where I miss, if that's okay.
What's your location?
I am in Pensacola, Florida.
Oh, nice.
So I am a military vet, retired from the Air Force, just recently diagnosed about 6 weeks ago. It was a result of a series of PSA numbers going up over the past 5 years. We have a lot of family history of cancer, specifically prostate cancer. My dad had it. Didn't die of it, but died of complications of the radiation. But that was like 25 years ago. So my general doctor we were always looking at my PSA numbers for the past almost 10 years. And over the past 5, it had gone up from below 2 to at one point over 7. So recently had biopsy. Biopsy had 2 cores that were positive. One was 40%, the other was 60%, and the Gleason score 3+3. I've had no other tests since, but as I said at the very beginning, I have my follow-up with my urologist tomorrow morning, where he sent off the cores for genomic testing. So we'll see what happens with that.
Let me backtrack a little bit.
Sure.
How did you hear about us at AnCan?
I was in another meeting. I just, probably like most other people, first thing you want to do is find out for some support groups. So I found one which was Zero. I don't know if you're familiar with that one.
I've heard of it.
So in there, I met a guy, or there was another guy who was a military vet, and he said, hey, I'm in these other groups. You might find these interesting. So he pushed me to AnCan, gave me that, and he's been very, very helpful along this journey thus far. So
yeah, I think we know who that is, right, Gary? Yeah, our secret shopper who attends the Zero meetings. But I also suspect, Dan, that he's probably told you all about our vets group as well, right?
Yes.
Yes. Okay. We know who it is.
Okay.
He's amazing. I just have to tell you, Dan, he is truly amazing.
Yeah. He is. I'm sorry. Go ahead.
Go ahead, Gary.
No, I was just going to reiterate what you said, Rick. The person we're talking about, I'm sure we're talking about the same person, is absolutely fantastic in the sense of all his knowledge of all the VA forms and everything that has to do with a veteran that is with this disease or any other thing that he's incurred during his service to the country. Be sure you jump on the vets group, because that's a bunch of information.
Yes, he's already. Yeah, he's connected me with all of those, and he's working with me to get my VA claim. I spent some time in the Middle East with burn pits, so prostate cancer is the presumptive cause for that, despite my family history. So I'm going to be filing for that as well.
Very good. Good luck with that. You couldn't be in better hands. That's for sure.
I gathered that in our series of email exchanges. So I'm very, very appreciative of everything that he's been providing, and all the guidance and help. I mean, that's all you guys know, I'm sure. When you start this journey, the first thing you want to do is, okay, let me gather some information, figure out what's going on. I'm not an engineer, but I understand the research. So go ahead.
Dan, thank you for your service tremendously. How old are you? I forgot to ask.
I'm 65.
Okay, seems to be a theme here.
Seems to be.
I think Jay was also 65.
Correct.
Yes.
Yeah. Okay. And you said you just had a biopsy?
Yes.
And was it targeted with a previous MRI?
It was not. So for the rectal and rectal exam, my urologist said it's stone cold normal, but because of your numbers and your family history, I recommend a biopsy. So we did a biopsy, and then
how many?
Lo and behold, they did a 12 core, and 2 cores were positive. One at 40%, one at 60%, both 3+3.
Excellent. That's very low, so that's good. It was probably a random biopsy of just a 12 core grid. No
Correct.
targets were done because you didn't have an MRI. Do
Right.
you know if your urologist wants to get you an MRI anytime soon?
Well, I don't know. We're going to talk about that tomorrow. As a result of the things that I have learned, much like Jay, I got a lot of questions for the urologist.
Dan, where are you being treated?
I'm not yet. So it was just the urologist. It's the West Florida Hospital in Pensacola, Florida. So that's where the urologist is. That's where my general practitioner is.
Okay.
I also have much. Yeah, it's just a local guy. And much like Jay, I also have diverticulosis. My dad had diverticulosis and diverticulitis, which when he had his radiation, it burned up a big section of his intestine and caused some of the challenges that he had as a result. He ended up passing away because of that. But so my urologist is, go ahead.
Well, just to interrupt for a minute, not having an MRI before your biopsy is not the way that it's done nowadays. What they do is they take an MRI so they can spot any lesions that might be there, and then target the biopsy based on what they see in the MRI. Being completely random, and I guess he went on the family history, but it actually should have been the other way around. Now, you heard us talk about second opinions, and I know you're just brand new into this, so hopefully you'll heed our advice and send the slides out just to confirm what they saw, or perhaps downgrade it, hopefully. And those would Eric, I believe, has already put those up in the chat window.
I pinned them to the
Zhao
top.
Okay, Dr. Zhao and Epstein. And also, if you would, we need your email. If you would put that in the chat, you can either send it to the organizers, or you can just put it out there, so we can make sure that you get the meeting notices and the pertinent information from AnCan itself. And Jay, if you would do that, did you put your email in the chat?
I'm doing that right now.
Okay, so yeah, if you two guys would put your email in the chat, we greatly appreciate it. So
just did.
Could I just Gary? Could I just add something?
Surely.
Okay. I'm not sure. So we had this issue last week, and I think it came up on Monday night in the low intermediate as well. where we had a guy diagnosed who had not had an MRI before his first biopsy. Michael's another one. It was J. I think what was his name last week? JW, something like that. Anyway, Dan.
That was Ed.
Sorry.
And that was a gentleman by the name of Ed, and we referred him to Kirsten Green. He had a blind biopsy with no MRI.
Right. And there was this other guy, Jay Wackhorse, Jay. Anyway, I guess if it were me, we don't give medical advice. We can't do that, Dan. But if it were me, I'd get my ass right out of that urologist before you go any further. And I'd start all over again, with somebody at a center of excellence. If we can send out your slides, but the problem right now is we don't know whether they've even biopsied the right place. And we can't do another biopsy for at least another couple of months, if not another 3 months or 4 months. And that's a real problem. Now, we can send out your slides and we can get them reread. But what we really want to do is get the biopsy reread once we know whether we're sticking that biopsy needle in the right place. And we can't really make decisions until that point in time. And to be honest, these guys, these urologists who are doing biopsies without doing MRIs, they should be struck off. That's not what the AUA, the American Urology guidelines say. And you can ask the guy tomorrow, why didn't you do an MRI first? You've really put me in a very difficult situation. But if nobody says anything to these guys, they keep doing it. And so we, as patient advocates, and you as your own best advocates, say, you did this ass backwards. You did it ass backwards. You know, you should have done the MRI before you did anything else. And that's what your guidelines say. How do I know, you can say to him, how do I know that you got the right spots? And he says, well, this is what we've been doing for years. And you say, yeah. And that's why too many men have been overtreated. But if we don't stand up for ourselves, the bloody urologists certainly aren't going to do it. So my initial thought is, Pensacola is a bit of a desert. We've had several people. We've got one guy, a younger guy with advanced cancer who's in Pensacola right now. You know, I would say to you, you've got to get yourself to, at least for diagnosis, to a urologist at a center of excellence who knows what the heck they're doing.
Any good recommendations? North, east, or west, or even south down the way? I mean, Jacksonville's not far with Mayo clinics there. Shands Cancer Center down at University of Florida.
Right.
UAB up in Birmingham.
Right. I'd stay away from UAB only because we've had guys who have been at UAB before and they haven't had much success. I don't know. Jacksonville, Florida is right in Mr. Tosca's wheelhouse. So he can talk to you about that. That's where he goes. We can certainly find, get some names for you, but don't invest. I mean, thank God it sounds like you don't have a major situation, so you can, you know, a critical situation, you can take your time, but you've got to get yourself over to a center of excellence, at least to do the diagnosis. And then if you finish up on active surveillance, which we hope you will, you do what Gary does. You know, he drives a couple of hours every so often, once or twice a year. But Gary, why don't you talk about who you see at Mayo Jacksonville and your thoughts on this?
Yeah, I'm in Melbourne, Florida, which is about 2.5 hours from Jacksonville, and I ended up at the Mayo Clinic. thank God to AnCan, because in a short matter of less than 2 weeks, they found a transperineal biopsy, which my doctor only did transrectal, and we're not big fans of transrectal biopsy. So I wanted a transrectal biopsy, and I was guided to a Dr. Julio Gundian, Gudian, at Mayo, and he also did an exact precision point transperineal biopsy, which is they only have to poke you once initially, and then they can move the needle around to where they want to go. That was after a biopsy. That was after an MRI. That's how they did it. So it was a targeted biopsy, transperineal precision point. I'm pleased with the portal is fantastic there. They've treated me well, and it is a center of excellence. So I would give a thumbs up at the Mayo Clinic myself.
All good information. I appreciate it.
Thank
And
you.
yes, after the biopsy and I got the results, we being my wife and I started doing some research, and that was kind of the question we had for ourselves, is why did we not have an MRI beforehand? So yes, that'll be a question I ask tomorrow.
Yeah,
And then
curious. I'd be curious to know his answer. Just put it out there, like Rick said, and ask him flat out, why didn't you do an MRI first? And come back to us next Wednesday and let us know what this guy said. Because I'd be curious. I'd be curious. I'm sure he's going to throw some kind of smoke, but I'd be curious what kind of smoke. Recently, of course, we saw the black smoke and the white smoke, but I'd be curious as to what kind of smoke he blows, because I want to hear the answer that he gives you to that solid question. Yeah, why didn't you do it?
Be firm but nice.
Yeah.
Yeah, I mean, I do think, Dan, when you put that question to him, you can put it to him in a nice way. You've put me in a very, very compromising and difficult situation. That's what you've got to tell him. I know Michael wants to get in because this is what happened to him, and he'll tell you his story momentarily. But I think you say, look, when you treat people this way and you don't treat them according to your own guidelines, you put them in very difficult situations. And as we as patients educate ourselves, you leave us in a position where we don't know what to do. And you can say to him, and it makes it harder for us to trust your advice. And you'll
ready to quote
see him.
I'm sorry, I thought you were done, Rick.
You'll see him retreat further and further into the depths of his chair as you talk. Go ahead, Gary. Hold on, Gary. Gary, hold on.
I would be ready to quote the guidelines. Quote right from the guidelines. You're saying, I'm reading right from the guidelines, and it says this.
Yeah.
What happened?
Before we open it up to the group, I do have a follow-up question about genetic and germline testing. Have you had any of that, Dan? The difference?
No, I don't know the difference.
So
if you're talking about, go ahead.
Yeah, genetics is based on your family history, your genes, and then germline is based on the cells of your biopsy slides.
Yeah, well, I think he sent off the germline and that's what I'm supposed to get tomorrow. And as far as genetic history, I don't know anything right now.
Do you know?
So
Decipher, does any of that ring a bell?
No, nothing was done. The only thing that was done is.
Can I just clarify? So the germline is your genetic history from your parents. That's the inherited. Okay. The inherited or germline is the same thing. The other test, which are the tests like Decipher and I always forget the names. Polaris, thank you, and all of those are the ones that really look at your own genes and how likely it is that your disease is going to progress. But find out what he sent off. He may have sent off for a germline. It would be good if he has. but if not, we can get you we can get you hook you up with a free germline test very quickly.
Okay. Well, family history is I've got cancer in my mother, my father, and my brother. My dad had prostate cancer, so I know that it's pretty prevalent, which is one of the reasons that we were watching my PSA numbers for a while.
I pinned the free genetic test from Promise in the chat at the top, so you can get that ball rolling.
Yeah, I mean, it doesn't hurt even if he's got it. You can fill in that. You can go to that website tonight and get the ball rolling, and you'll get a free test. They'll send it to you. It's a solid and a good test, but it's not the most comprehensive. If your doctor's ordered one, it's probably going to have a wider panel.
Okay. All right. Good to know. And not to pile on my urologist, but he initially asked me the first time he told me that I had cancer, went through the biopsy. He basically pushed me to surgery or radiation, and I told him, "Well, I'm kind of leaning toward active surveillance." He didn't seem happy with it.
That's why you want to turn around and leave.
I'm picking that up.
Yeah. If you're picking that up, you're doing a good job, because that's basically what we're saying. Time to move on. Michael in Tennessee got something to add. Go ahead, Michael.
I'm sorry. Yeah, I did not expect to be talking so much tonight. But Dan, what Rick said absolutely hit home for me. I went down so many different avenues, so many different tests, and I kind of have to start over. For the exact reason he mentioned, I did not have an MRI prior to the biopsy. There's really no. I mean, somebody correct me if I'm wrong, but I don't know that doing the Decipher test is really going to help you much right now. I got my results, but if they don't exactly get the right tissue sample, then you can't really rely on them a whole lot. That's why the MRI is so important. So for me, I was diagnosed in January. I had to wait until April to actually have my MRI because it has to heal. So it does. They really did put the cart before the horse. So just to kind of narrow things in for you, that Promise color study is something that you can safely do right now. It doesn't require tissue sample. It's just a little spit test. I would absolutely, go through the process I did. I kind of had to fire that urologist, right? And just kind of start, and I'm starting all over again. And so you can save yourself a lot of headache if you just let your body heal a little bit. Sounds like you're in a good spot. Get the Promise Color study link that he has in the chat, and get that MRI as soon as they feel it's safe. Because any PSA testing you do right now, any genetic testing they do right now, even the PSMA, all that stuff can get skewed. So just to kind of really hone in on where you're at, you're kind of stuck a little bit, just waiting for your prostate to heal, and then kind of backing up and punting, right? You're going to have to do it all again with that MRI started. I just want to simplify things for you because I went that whole process and then realized, dang it, now I got to do it again. So
yeah, well, it's better to get it right than to rush into anything.
Yeah.
And again, you have time, just like I told Jay. Time is on your side. I jump on the color. I jump on the Promise study. And yet you unfortunately have to wait a while before you can proceed. But don't. We talked about anxiety. I don't know. I usually ask on a scale of 1 to 10, how anxious are you about this disease on a daily basis?
2, 1 to 2.
Okay. Well, that's good. That sounds like that's under control. That Men Speaking Freely is a great group where you can go and just kind of talk about anything and everything. So that would be a good option also. And then it's a shame that you've got to start over, but a fresh set of eyes from a center of excellence, following the guidelines, doing the right things, doing the right things after getting the PSA, getting the MRIs, the biopsies. Certainly you're certainly you're where you should be from everything that you've told us. You know, we're not doctors, but everybody is on this journey, and we're all in different places. And right now you fit in from what we know. And a lot of these people, including Rick, know a lot about this disease, know a lot about the ins, the outs, the do's, the don'ts, the where and the where not. So just hang with us. Thanks for joining us this evening. You also, Jay, and thanks for sharing, because sometimes it's tough. One of the problems with men, a lot of times they don't like to express their feelings, or they keep things under covers for whatever reason. And this is a group where we're all in the same boat, and just kind of like tell it like it is. Ed, you have something to ask Dan?
Well, hold on. I just want to add a couple of things to that, Dan. First of all, keep coming back to this group because you'll learn a huge amount. Ask Michael. I mean, this is where he picked it up. Oh, it was Jeff W. That was who it was last week. You should have said something, Jeff W., or waved your hands. Now I see you there. It was Jeff W. who also had a similar issue to this last week. And
now you might be thinking of Billy Hayes.
Oh, and maybe it was Billy Hayes. Maybe it was Billy Hayes. But did you get an MRI before your biopsy or not?
I did, yeah.
Oh, okay, so it wasn't you. All right. But the other thing I wanted to say to you, Dan, is that we also have a Vet Speaking Freely group. And that's for you. That's a mixed group. It's men and women, but it's for you as a vet to get anything off your chest that might be bothering you from your service or anything else. It's a discreet group. We've just started it because the vets asked us to start it, and you're signed up for that. Whilst you may not be concerned about your prostate cancer, and it's really good to hear that, if you've got any problems from your service, issues from your service, that's going to be a really good place to be able to wear them out for you. So that's another thing. So sorry, go ahead, Gary or Eric.
Yeah, Ed, did you have a question for Dan?
Actually, I wanted to follow up with something that Michael said. I'm in a similar situation where I had a blind biopsy done before the MRI. So I'm kind of starting over. Found another doctor and I'm getting an MRI. It's scheduled in about 5 weeks, which will be only about 2 months after the initial biopsy. Is that too soon? You said something about you waited several months.
They told me that even whenever I waited until the 1st of January was the biopsy, and mid to late April. I want to say the 25th was the MRI, and there was still a lot of blood present. I think it's different for everybody. I mean, I don't know if I can speak for everybody in the room, but there was still a lot of blood present to the point that they actually want to do another MRI here in a couple months, just because it just kind of convolutes things. So you just want to make sure it's healed.
So you might have, of course, on the advice of your doctor, Michael, it turned out, like you said, too soon. Now you have to do it again. So that would be a concern. I'd talk over with the doctor in a little bit more depth, Ed. I don't know if you have any blood present in your urine at this point. See if he feels that it's okay for you to do it, or again, time, it's not like you have to go do it tomorrow. You want to give yourself another couple of months. I'm sure that's not going to have any critical importance in the big picture. You know what I'm saying? Like I say, we're not doctors, but waiting another 2 months to make sure that you're healed a little bit more, maybe a little peace of mind, it would be worth it. So I think that would be something I would discuss with the doc.
And it would also matter how many cores they took. Like for me, it was 17. So I don't know if that played a role or not. But
yeah, my blind biopsy was 1 out of 12. 1 out of 12 cores, Gleason 6. So, but he told me I could get the MRI 6 weeks after the biopsy. Now that sounds like that's too early.
I mean, I say go ahead and do it. The worst thing they're going to do is make you do it again.
That's true. Okay.
And you don't have to have contrast each time. Well, I'm sorry. Again, I'm not a doctor either. It's just that with the right set of eyes, they can do it with or without.
Okay.
And maybe Eric can speak on that.
That again is one of those issues that is always on the top of debate. They're still talking transperineal versus transrectal. There's a seminar coming up about that, and also contrast and no contrast. This guy Gundy in Mayo, he likes contrast. I'm going to question it the next time I go, because as the patient, you're the boss. If you don't want that stuff, gadolinium, I believe, is what they use. There's some studies that say some of that stays in your brain. I don't know. I'm not a doc. I didn't read in depth, but you have the choice to say, no, I don't want contrast. And I don't think they're going to say, no, I'm not going to do it because you don't want contrast. So that, there's always those areas where you're going to, have a difference of opinion. But 6 weeks sounds a little early to me. But like I say, I'm not a doctor either, but I think I'd give my body a little bit more time to heal. Ed, how old are you?
67.
Okay. Well, yeah, of course, I don't know your general health or your health history, but I think I'd feel a little bit more confident. See, now I'm claustrophobic. I got to take I got to take goofy pills to get in the tube. So the last thing I want is somebody to tell me, oh, we got to do this again over my dead body. They ain't doing it again. Once a year is about the max I can do. So I don't know how friendly you are in an MRI tube. If it's no big deal to you, that's one thing. But it's still the anxiety of getting an MRI, the scheduling. Somebody's got to drive you home. Blah 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 blah. Yeah, I think I'd wait a little while myself. Does anybody else have anything for Dan?
Yeah, where did we leave off for Dan as far as should he get a second read on his biopsy or not?
I mean, if it were me, I would wait and get. I don't see the point because first of all, we got to make sure that we get the right biopsy cause, and then we need to make sure we know what they are.
Okay.
Because it's not, it's going to be money, it's going to be time, not time, but I don't know that it's going to help.
Okay.
Just see what this doc says, take that with you, and when you go to the next doc, you say, you can tell them up front, I'm going to get my biopsy reread by either Dr. Epstein or Dr. Zhao. I just want you to know up front, and then arrange for them to send it off as soon as they've had them read locally. Dan, did you get the name of Gary's doctor? Because he went over that quickly. Or Gary, can you put it in the chat window?
Absolutely. I'll put it up in the chat.
Thank you. So,
any other questions for Dan, or Dan, do you have questions for us?
No, I don't have any questions. I appreciate all the information. You guys have been very helpful, and I will definitely be back.
Please come back.
And I'm connected with the other groups as well. So I signed up for a few of them actually in the low risk as well, just to hear different perspectives.
Thank you.
Yeah, well, what you'll hear in the low risk is about treatment options. We don't talk about it here because some of the guys don't want to listen and hear about treatment options until they're ready. That's the only reason why. So we have a separate group, and when they're ready to talk treatment options, you just move to that group.
Makes sense.
I am just going to intervene for a quick second.
Okay.
And I'm just putting something in the chat window. And this is something you'll see in all the reminders, probably for the next 2 or 3 weeks until we get there. But each year we have to get 10 new testimonials on GreatNonProfits so that we can maintain our GreatNonProfits seal. If you look on the website or on the reminder, wherever you see it right now, it says 2024. So we got to get it for 2025. if you have written one before, you can't write one again. But if you've never written one before, or you're new and you just found us, like Jeff W., you can go and you can write one on there right now. So we would love for you to please go to Great Nonprofits. The link is in the chat window. The other place you can find the link, which is even easier, is on AnCan.org. If you click on testimonials at the very top, it takes you straight there to where you put in the story. So please, if you haven't put it, shared your story and spoken up for AnCan, we'd love for you to do it. Thank you very much.
Awesome. Thank you. So I know, Michael, you wanted some time and you also have your hand up.
I'm sorry. Yeah, I was just going to add, Dan, another thing that, and please, somebody correct me if I'm wrong here, but there's an epi switch test that you can have done that's not related to tissue either. It's similar to the Decipher, but it uses it's a blood test that you can have done that looks for the aggressiveness and grades it.
And that's epi switch?
Epi switch, yes.
Did you have it done as well?
I did. Yeah, I sure did.
And how did they have a scale like 0 to whatever? Is it like similar?
Yeah, it is. It's very similar to the Decipher test. It's from Oxford, I want to think. I think it's a weird domain. Hold on. Yeah, Oxford Biodynamics. It's 94%.com is where you can get information on it.
You want to put it in the chat?
Okay. Yeah.
Thank you.
Okay, great.
And did you have something for us, Michael? Your questions for the group?
I'm just going to give you kind of an update, but if it's not super important if other people want to talk.
No, go ahead, Michael.
So I'm starting over, right? So I think I've kind of established that with my yapping before, but I've got, and this is something maybe of interest to everybody. So for Dan and Jay, I went through this whole process without having the MRI first, and then when I had the MRI, it looked, what was on the paperwork from all these different tests and all the things I'd done didn't match up with what they saw in the MRI. So the MRI looked way worse than what I was seeing because they didn't actually target the area that needed to be targeted. So I'm going through all that again. So I guess something to share with you guys, if for what it's worth, and Dan, this may help you as well, or Jay. I'm in Chattanooga, Tennessee, and it's hard to, I can't find a center of excellence that I really trust really close to me. I was able to reach out to UCLA and send them my entire everything that they had done from mainly for the MRI. That's what I wanted a second opinion on, and they'll actually do that for you and call you and your doctor. They can't give the patient direct information without their doctor present, but if your doctor is willing to sit there and take that call with you, then they'll review your whole case, make the recommendation based on the MRI as far as what. So even though you're not at UCLA, they can kind of direct the doctors here in Chattanooga as to what they want done, if that makes sense. It's kind of a pain to schedule UCLA's doctors in line with my doctors. That's kind of a hassle. So if you can find a center of excellence near you, that'd be better. But that was a really unique service that I did not expect to find. I hadn't seen anybody else do that. So just wanted to throw that out there for anybody who's in a remote location. You can call UCLA and they'll work with your doctors and kind of guide them.
That's great.
So
So that's interesting.
Very good.
But that's where I'm at. I'm still that's supposed to happen Monday. at noon. So I'll figure out. They've already. What's neat about them is they got a whole team, right? I found out when I went to a urologist, they wanted to cut. If I went to somebody else, they wanted to radiate. Went to somebody else, they wanted to do TULSA. Went to yeah, everybody wanted. Everybody had their own recommendation. And
Just finish it up. Okay.
the unique thing about UCLA is they have a team that actually they argue it out amongst themselves and then kind of get back to you. So I found that very fascinating. That may help.
Yeah, it's kind of like the VA. The VA doesn't have a horse in the race. So when you go get advice from the VA people, they're not going to operate. They're not going to make money. They don't own a piece of the center. They don't own a piece of the MRI machine. They don't own a piece of anything. So I find, being a vet myself, when I get information from them, it's basically from their knowledge and from their heart, because they're working for the VA because they have some love for what people did for the country. So and that's the thing about UCLA too. They know that you're not going to, that there's a good chance you're not going to go there for their services, but they give you that, that brand new, fresh look, and talk to your doctor. And most I throw out things that are, that perhaps he or she might not have thought of, or, UCLA is such a big place, center of excellence. They're on top of everything. So something like that's really invaluable. I wouldn't think that they did that either, Michael. That's good to share, because I wouldn't think that would be available. But that's kind of like how I feel about the VA, because you go there and they don't have a horse in the race, so they're going to tell you the truth. It's not like they don't want you to bet on their horse because they don't have one. So very good though. That's, and be sure to come back and tell us how the phone call went. I can't wait to find out talking to the urologist that didn't do the MRI, that conversation, and now your conversation with the UCLA people. Everybody should come back on next Wednesday, because it's going to be a good one.
Yeah,
please. True. Thank you for letting us know. That's great information.
Thank you.
Anything else for us? Otherwise, we'll move on.
No, just thank you. And I agree, for the new guys, definitely come back. They have, I don't know. They clicked to let me know that it never made me feel like I knew more than my urologist did.
Yeah, that's what we want to hear.
And it's one of those things where sometimes what I've definitely learned is with a lot of these guys, their cure is way worse than the disease. So it's really weird when you talk to these guys how quick they are just to throw you into whatever procedure they're best at. So just be leery of that.
You got to make a buck, Michael. You got to make a buck.
They got to both able to make.
Well, I'm sorry. What was the test? Because I want to say something about this. What was the test that you said that UCLA was that you wrote to UCLA about?
It wasn't a test from UCLA. So internationally, UCLA can consult with anybody, but within the United States,
okay,
they have to be licensed in your state, and because of that, they'll still consult with you. Now that they're using their international program, as long as your doctor is present, they'll consult with that doctor, if that makes sense. They can't consult with you as the patient. That's illegal. but they can consult with your doctor.
So what I was just going to mention to you about UCLA, and we will be putting this in the active surveillance reminder, even though it's not really for you guys just yet, is we had a great seminar before the low intermediate meeting on Monday with Dr. Joanne Whitehouse, who has developed some interesting tests. She's a radiation oncologist, and she's developed some interesting tests at UCLA, including a test to see how sensitive you are to SBRT. Actually, whether you do better on SBRT or on IMRT, those are types of radiation. And we didn't publicize it to active surveillance. But anyway, you'll see it coming up, and if you feel like watching it, you can watch it. But she's delightful, and it's a good hour webinar.
I think it's last question. Anybody familiar with Dr. Rahman out there? Rick, have you heard of him?
No. Oman? No.
Rahman.
Oh, Rahman. Yeah, I have heard of Rahman. Why have I heard from him? I'm not familiar with him, but I've heard of his name.
He's the one that's going to be delivering whatever they reviewed. So,
okay.
I was just curious.
All right. Well, we'll definitely look for that. Look for that next week. I know Alan said he was. I know Alan said he was confused, and I said that everybody's confused. So tell us about your confusion, Alan.
Well, at my brother's urging, I went and saw a radiation oncologist at MSK today to establish the relationship. First words out of the man's mouth is, I highly encourage active surveillance. But then as the discussion went on, he says, you know, at your age, because I'm 63, 64 in July, he says 3 to 5 years we'll likely end up having to treat you, which was depressing. And his second comment is he was pushing me or encouraging me to go back to Weill Cornell and get into their trial program for active surveillance. Primary reason is that the trial would pay for a PET scan. I don't know. I'm confused. I told him I had seen Dr. Eastham at MSK, and he almost, I won't say he was dismissive, but he was more encouraging that I should be in the trial at Weill Cornell, although he did tell me the trial is coming over to MSK later this year as well.
Who did you see, Alan?
Nagar.
You know, sometimes I think too much information, you know, seeing too many people can be too much information. To me, I wouldn't have gone to Nagar. Me personally, I wouldn't have gone. I would have stuck with Eastham, let Eastham manage it. And when you're ready to see a radiation oncologist, you see the radiation oncologist, because this is exactly the problem that it creates.
Yeah.
You don't need a PSMA scan. You don't need a PET scan.
I told
so maybe they'll pay for it. Maybe they'll pay for it, but what do you need it for?
Sorry to interrupt, Rick. I said to him, I've been told now that it's premature for me to have the scan. He says, well, what we're looking at, which I felt like I was being pushed towards the study, is that ultimately they think the study that a PET scan can prevent future biopsies or reduce unnecessary biopsies.
Yeah.
But, you know, I don't need to be the guinea pig.
Well, that's right. You know, I mean,
at Eastham, I think, is my decision still. The other thing was, because MSK can be difficult to get, we had to fight a little bit to get me to Nagar versus an unknown at MSK. It was like, go see Nagar because now you're Nagar's patient. If you ever need him, you have the relationship.
Well, I can't disagree with that. That part I can agree with. But, you know, if you're willing to run around at this point in time for the sake of being Nagar's patient in the future, yeah, it was a smart move to do that. But we don't need, we try very hard here with our active surveillance men to only put things into your head that you need to think about, okay? I was just sent an email by somebody, one of our moderators, asking, what do I think about Dr. Wassersug's study for everybody on what your opinions of androgen deprivation therapy are and estradiol. I told Wassersug, we're not sending that to our active surveillance men. Well, why? Why don't you? Why? Because we don't need to fill their heads up with androgen deprivation therapy. They don't have an opinion about it because they don't need it. Right. So why are we even asking them? Well, he's a researcher. He wants to make sure that he's covered everybody. I care about our participants. And I just wrote back to the person and said to them, no, we didn't submit this to all of you, and all you moderators, you active surveillance moderators, are going to see this in your email. I wrote back to them and I said, no, we didn't, because you guys don't know anything about it. You don't need to know anything about it. When you're ready to know something about it, we'll make sure you know the right stuff. But we don't want you worrying about what hormone therapy does to you. You're dealing with enough just with this threat of cancer hanging over your head. And this is, it's the same thing with these doctors. Yeah, oh yeah, get him a PSMA. You don't need a PSMA PET. You'll get it when you need it. You know, I have a problem. As much as I have a problem with these community urologists and radiation oncologists who are running procedures when they don't need to run them and trying to run you onto the operating table before you're ready, I have a problem with the academics who are trying to push you into studies that you don't need to be in. Yes, studies are great for the right person, but they're short of bodies, so they, you know.
That's exactly what I ended up feeling like today, Rick. The only thing that bothered me or upset me, but I'm discounting it, was his comment of, well, I'll see you in 3 to 5 years because we'll end up having to treat you.
And that's bullshit. He had no right to say that to you. And that really, and if I ever said that, if I ever seen the guy, I would say to him, don't be saying that to these men. You don't know. 30%, 33% of the men who have 3+4 never get treated. Do you have a crystal ball to know that Alan J is one of those men? Or not one of those men? How dare you say that to him?
He may have said it because he knows my brother and knows that my brother had to be treated. But no, both McClure and Eastham, as well as Stacy Loeb, said, we don't know. And they all actually said the odds are fairly low that you'll ever be treated.
I agree,
well,
and it's inappropriate.
Go with those guys.
I'm going to stay with Eastham. I'm going to proceed with Eastham for a while, see how it goes. If I have to go to Eastham, even said if you progress, I can send you back over to McClure.
That's right.
Or I now have the relationship with Nagar if I ever need it. But Eastham,
there you go.
I'm 95% convinced. Eastham is the start, and we'll see how it goes for the next 6, 9, 12 months.
Alan, since discretion is the better part of valor, I won't say anything to your brother. You can say to him. You can convey it to him.
When this ends, I'm about to call my brother and tell him that you pushed me to go to Nagar, down Nagar upset me.
There you go. There you go.
Drink or something.
No, but you know what? It's good because then he realizes, because this is, you know, this is what happens sometimes with these docs. They don't have, I won't go there. Anyway, besides, I understand.
You know my brother, he's never met a doctor he won't go see.
He, very unprofessional, though, the guy to tell you, well, I'll see you in 3 to 5 years.
Yes.
That's not cool at all.
That's just total bullshit, unprofessional, especially for supposedly a man of his stature, where he's employed and supposedly what he does. I mean, that's sad. I mean, that's just sad, really.
That was the one upsetting thing, that is the odds are you'll end up being treated because you're young.
That's cruel.
Yeah, really.
Do you have any other questions for us?
No, just to update you and then tell you that's why I'm confused, but I think I know what I'm doing.
Yep, you know what you're doing. Just stick where you are with Dr. Eastham and, forget about today or whatever, Dr. Niger. Okay, Andreas, you got something for us, buddy?
Yeah, and it's kind of along the line we were discussing, and it's a clarification, and I apologize for anything if it is too naive a question, but I want to hear from you. So
yes.
many times I hear, 3+3 will never progress, and a lot of people will say never, and that word, just carries a lot of weight, never, and people in same conditions that are not in this group, they say, oh, I'm not even bothered about it. I don't even bother doing another MRI. I don't even bother about another biopsy because it's a 3+3. So in the same time, when we read the studies, or I listen to some of the videos that we post here in AnCan, then some of the studies, they say, well, a percentage of so-and-so will progress into 3+4, 4+3. So that's not never to me, right? When you have like a percentage, 15% of people will go progress into treatment from 3+3, By the same token, there are also people that have 3+3 and then go back to 0, right? So
I can explain this to you.
Yes, please.
I can explain it to you, okay?
I have a
But you're 3+3, right?
Yes, I am.
Yeah, well, after you told me the result last week, it may prejudice my answer, you know?
Yeah, I told him.
By the way,
By
the way, I didn't watch the whole game, but they did play very well in that first 20 minutes. They did. They did. And if you hang on afterwards, I'll tell you what I did with the Liverpool game. But let me explain to you because it'll make sense.
Right.
What we're saying is this. If you are a true 3+3, you will never progress. And never is a long time, and never means never. Now, how do we know if you're a true 3+3? Anybody? Can anybody in the group tell me how we know you're a true 3+3?
Targeted biopsy. I'm right.
No. There's only one way to know if you're a true 3+3.
Oh.
That's to have surgery.
Take it out.
You have your prostate removed. You slice it up. And we see that there was no sign of 4 anywhere. Now, we don't recommend you do that. But we can tell you that if, in fact, you are a true +3, you won't progress. That's the first part of the answer. The second part of the answer is you're on active surveillance. In all the times that everybody's been in this group, I think Alan's reaming out his brother. I'm sorry, I'm watching him on the telephone there. I think he's giving his brother a mouthful. If you've never heard us talk about watchful waiting. So there's a difference between watchful waiting and active surveillance. Active surveillance means you're constantly monitoring what's going on. So if you're a 3+3 and that's becoming a 3+4, because yes, about a third of people do progress, we're going to see it progress because we're going to see it on an MRI, we're going to see it on a biopsy, we're going to see it on a PSA movement. So we're looking for that all the time. So I understand how it can be confusing because you can say, well, some people do go to a high level. Well, yeah, those people were never true 3+3s in the first place. So you've got to be watching all the time. Now, one thing that the studies have shown, and Dr. Carroll's cohort at UCSF has shown this, and other cohorts like Canary, is that the consensus is that you don't do any worse by waiting. So even if you wait and you go to a 3+4 and then you get treatment, the outcomes are no worse. So does that help you understand?
Yeah. And I also thought that doing another MRI, you might have 3+3 now with what you have, but you might develop other right along what you have already having additional.
Yeah.
Additional cores you might have.
You could develop additional cores. That's why we're always watching.
Mm-hmm.
Right, Mr. Tosca?
Correct. The targeted MRI, an MRI every year, and then of course, if they see the same lesions as they have in my case, thank goodness, there's no need to go any further. Of course, the last time I was there, he said, well, maybe we should do another biopsy. And I said, well, I'll think about it. So that's, that's where I am. I'm it's been a while since I had a biopsy, but I think that, again, that's a personal choice that I have to make or whatever. But that's the only way. It all goes back to active surveillance. Like Rick says, things can change. But if they do change, you're right on top of it because you've been watching it all along.
Yeah.
And then, of course, with the most information and the best data that's out there, and as I've said many times before, maybe for the first time for the new guys, it's ever changing. The diagnostic treatment is ever changing. These studies are, you know, sometimes they do 5, 10, 15-year studies. Sometimes that's when finally the results come out. I think Howard posted something today that there's a promising urine test that'll stand side by side to a PSA test. That it might be more successful in predicting the evidence of cancer than a PSA test. And of course, these are all new things that are being studied, that have to be looked at. But the longer you can wait, the more things are out there, and the better chance you have of all the new treatments, focal treatment, and somebody mentioned the other one. I can't think of it off the top of my head now. But the longer you can hang out, the better. But stay on top of it, because your body can change. The 3+3, we've had people that goes away. They've had 3+3 lesions, and then the next MRI, poof, it's gone.
Yeah.
And that's good. And that's a good thing. And then, of course, unfortunately, it can turn the other way. But here
Right.
again, we've got people, you know, top of the line professionals saying if somebody has, you know, a core of 3+4, less than 5, even I've read to 10%, they can go on active surveillance. We've got the tools to watch, and we've got it's ever expanding. So
the imaging is so important because it's non-invasive.
Does anybody else? Oh yeah, Alan's still on the horn with his brother. Yep. Does anybody have anything else? As I said, new people, please come back. Thanks for sharing. It's great to have you come out, and thanks for all the input from the other gentlemen. We appreciate that also. But with that, I think anybody have anything in closing?
I'll stop
Rick,
the recording.
No, come back to Speaking Freely tomorrow night. We'll be here tomorrow night. Make sure you put a testimonial in on these. This is all your homework. Testimonials on non-profits, Speaking Freely. These are all the right things to do. Okay,
Yes,
and come back next week and we'll help you.
All right. We're gonna hang around for a minute, Eric.
Yeah, just for a second. Andreas is allowed to hang around for a second too.
Okay, good night, everybody else. Take care.
Thank you.
See you
Thank you.
next week. Okay.